Once we have taken the detailed history, done with the examination and checked all whether the points are present or not, and we have done our Pirani scoring, then we go for the imaging. Why imaging is important? Because despite the modified Pirani score, also it's a clinically we know it's a clubfoot, but we need to measure the angles, how much pathology is present and how much correction needs to be done. And when we are getting the x-rays, as you know, the foot is actually in the plantar flexed position with slightly varus. So what is done is that when you're taking the AP and the lateral views, we ask the radiographer to make it maximum dorsiflex which is possible. If the foot is coming till neutral, he or she should get the x-rays done in the neutral. If the foot can be dorsiflex, it should be dorsiflex, and then the AP and the lateral views should be taken. So this is very important to understand, because until unless if we have the views are in the plantar flexion, then we may not be able to assess the pathology which is present in the bones, and they may look very much normal. Therefore, whenever you are getting an x-ray, you have to order an x-ray AP and lateral view in maximum dorsiflexion, and both we have to be taken separately. Why we need to do is because we have to calculate certain angles on AP as well as on the lateral view. When we are viewing the AP view, you can appreciate this is the talus, this is the calcaneum. Normally they are much divergent as compared to this. Usually there is an angle between them which is called as the talocalcaneal angle on AP view, or kite angle. It's normally between 20 to 40 degree if you appreciate it over here, but it actually decreases than the 20 degree, and you can see it over here that probably 35-40 degree of angle is present, and over here it has decreased about to 5 to 10 degrees. So on AP view, when we are calculating the talocalcaneal angle, it goes down to less than 20. There is another angle as well called as first metatarsal angle. Why is that calculated on AP view? The reason is that actually the problem is at the naviculum, but if you appreciate it over here, you cannot see any naviculum in between. Why? Because naviculum starts to ossify by 2 to 3 years of age, and this is a child who's a neonate has come to you for the assessment. Therefore, can we actually calculate the angle in absence? Because when we cannot see the naviculum, the way is because this naviculum would be articulating with the first metatarsal, and you can see the ossification of the first metatarsal. So we take the first metatarsal axis as a reference point to the naviculum. So instead of calculating talonavicular angle, we calculate the talo first metatarsal angle, and usually it's normally between 0 to 20 degrees in a normal foot. If you see calculate on AP with the talo first metatarsal angle, it's usually in the negative. When you calculate it, comes out to -5, -10, and even -15 as well, depending upon how much foot is problematic. If you see, they've calculated talocalcaneal angle. This is the talus axis. This is the first metatarsal axis. Can you appreciate how much is gone? This almost -30 or -40. But this is the normal foot. This is the axis of the talus, and if you can appreciate over here, this is the normally it's in positive. But in case of CTEV on AP view, the talo first metatarsal angle would be in negative, and talocalcaneal angle would be less than 20 degree. A normal talocalcaneal angle is about 20 to 40 degrees, and normal angle is usually in talo first metatarsal angle is in positive. Then we have to calculate the angles on the lateral view as well. Again, on the lateral view, that is why we calculate the angle in maximum dorsiflexion. Now, although you can appreciate there's a lot of plantar flexion, but probably this is a rigid foot, and despite the maximum dorsiflexion being done, although we could not really make it come to neutral, but you can appreciate the hind foot parallelism which is seen in the congenital Talipes Equinovarus. That is, the talus and calcaneum appear to be their axes appear to be parallel to each other, and that is called as hind foot parallelism, which is seen in the congenital Talipes Equinovarus lateral x-rays. When we calculate further angles on we have to calculate actually the talocalcaneal angle as well, and when we are calculating the talocalcaneal angle, it's usually difficult to calculate because of the hind foot parallelism. But if this hind foot parallelism is not seen, then probably this is not congenital Talipes Equinovarus. It is probably CVT or some oblique talus as well. So you have to keep all those differentials in your mind along with the diagnosis. Therefore, you have to confirm your diagnosis by calculating the angles on AP and lateral view. And once we calculate the angle on AP and lateral view, we are sure that it is CTEV as compared to CVT. This is, if you see appreciated over here, this is the angle being talocalcaneal angle being calculated, and this is another maximum dorsiflexion is being done to calculate the talocalcaneal angle. And normally on lateral view it should be between the 20 to 40 degrees. And when we are done with the x-rays, we are absolutely sure that it is congenital Talipes Equinovarus, and we have confirmed with our Pirani score as well as our x-rays. Then we will move on towards the management of the disease or treatment.